All right, in the interest of time, let's go ahead and get started. We have two presentations today. The first from the Advara team to talk to us about eReg, and then Michelle Edelman is here to talk to us about Health Data Compass. And then at the very end, we'll have one survey question just about your role on campus to get an idea of who's attending these meetings. If you could, please ask questions in the chat while the presenters are speaking, and then we'll go over questions after they stop their presentation. Okay, with that, I'll hand over to Terry from Advara.
Great, thanks so much, Ben. Give me one moment here. I will share my screen with the group. Can everyone see my screen? Okay, yeah. Great. So thank you so much for inviting us to present to your group today. We're very excited to be providing an overview and in-system demonstration of the Advara e-regulatory management system. So the system is currently live at UC Denver, so you'll have access to start using the system now or today if you're not already doing so. So my name is Terry Chase, and I am a customer success manager here at Advara. And joining me during the presentation today is Angelina, so I'll allow her to introduce herself.
Hi, good afternoon. My name is Angelina Fiorito. I'm a solutions consultant, so demoing for you all today and excited to do so.
Great, thanks Angelina. And also joining us is Mackenzie.
Hi everyone, I'm Mackenzie. I manage the Solutions Consultant team. I'm here to help answer questions and monitor the chat as we go throughout the demonstration.
Great, thanks. So for our portion of the next hour, I will be providing a brief overview of the system for just about the first 5 minutes. Then I'm going to hand it over to Angelina to show us the system, and that'll be about the next 20 minutes after that. And then we will have about 5 minutes at the end for questions. However, in the meantime, please submit any questions that you have in the chat feature. We will try to answer those real time. And if there's any questions that we're not able to answer, we will take those as follow-ups and provide answers to those after the demonstration. So as a refresher for the majority of the group, Advara eReg is our 21 CFR Part 11 compliant system that streamlines your regulatory compliance and quality assurance workflows. It also houses all of your essential protocol documents to really help maximize efficiency and reduce that regulatory burden. So how does eReg do this? Well, first, eReg can help to accelerate the startup time by utilizing integrations that are available. So one such integration that we have is the document integration. With this integration, as you start to add your regulatory binders to the system and manage these within eReg, you can use that templated approach so that your full binder structure is already set up and ready to use with just a few clicks. Secondly, eReg can help maximize the use of other integrations that we have available, such as integration with your IRB platform, integration with your CTMS system Encore, or email to really easily get started and kick off processes like getting some of those essential protocol documents in the binder or allowing staff to initiate that delegation of authority process very quickly. Then thirdly here, eReg enables remote workflows. So because eReg is a web-based solution, this allows folks to complete really any step of the workflow, not only in an electronic format, but also remotely. Fourth is a focus on compliance. So as I mentioned earlier, eReg is 21 CFR Part 11 compliant and validated. So we continue to provide a lot of support with validation efforts ongoing, just to really help organizations be confident that the system is set up correctly and can be used in a very compliant manner. And then lastly, eReg really simplifies that monitoring process. So eReg is really a great place to store documents and facilitate workflows from a site perspective. And it's also set up to allow folks like sponsor monitors to very easily and remotely view binders, view subsets of binders, as well as source documents in a secure and compliant fashion. So you don't have to pull that paper binder together. Our E-reg system is well adopted across the US in institutions very similar to yours. We have over 6,000 users actively leveraging E-reg today. There are roughly 515,000 documents that are being managed electronically in the system. We have over 4,700 protocols entered into the system, and there have been over 4,500 remote monitoring sessions. So one area in the regulatory process that can take a painful amount of time is running around various buildings or campuses to track down those wet signatures. So I know you've all been there at one time or another, but in a recent study we conducted, folks who are using an electronic system for collecting signatures resulted in a 94% reduction in time to sign versus tracking down folks for those wet signatures. You know, just think about that for a moment. 94% time saving in one step of the regulatory process. You know, think about what you can do with that time you get back from using an electronic signature workflow. And so along with the benefit of the electronic signatures, E-reg also has fully integrated workflows that are live and ready to be used. So E-reg integrates with Advara's IRB platform Kirby, also has integration capabilities with your local IRB, email integration, as well as an integration with Encore and other participating sites with an instance of Advara E-reg. You know, so with all of these integrations that you have access to, the result is that fully integrated electronic regulatory workflow. So with this fully integrated workflow, you can see a true time savings of over 16 hours per protocol to really help keep your research on track. You know, and just beyond that time savings, integrating with systems like Kirby and your local IRB will help to eliminate any mistakes made in having to upload documents. So a lot of really great benefits to start using the E-reg system today. And with that, I will hand it over to Angelina for the in-system demo to really show you the workflows and the integrations that I just talked to. So as a reminder, please continue to use the chat feature and we'll try to answer as many questions as we can. So I will hand it over to Angelina.
Let me just go ahead and share my screen. Okay. Okay, great. So you all can see my screen? Terry, thumbs up. Great. Okay. So we're looking at the home screen here, or the jump off point when you first log into E-reg. You'll notice a few widgets here, which bring the most important things right to the forefront. So that includes your personal favorited protocols or documents which need to be reviewed. So we tried to make it as easy as possible to get to what you need to access, you know, right from the home page. As a note, this E-reg logo in the top left of the screen is an easy way to get back to the home screen, no matter where you are in the application. And you'll see—
Angelina, I apologize. Could you bring the mic a little bit closer to your mouth? Or turn up your volume just a little bit.
Okay, yeah, just give me 1 second. Let me see if I can edit my volume within here. Okay, is that better? Hopefully a bit.
Yep, that's better. Thank you.
Okay, just feel free to jump in again. I wanted to make sure everyone can hear me when I'm going through. So as I was mentioning, to the right of the E-reg logo, we have the menu here. This is the drop-down menu that's used to navigate E-reg. This favorites bar across the top is actually customizable. So you see these stars here. You can easily add and delete things from the favorites bar. So if you'll look at reports here, you know, you can easily add it, take it off, to make it so that you can easily access which pages you need most frequently right from your favorites bar at the top. Okay. And we can go ahead and jump into the regulatory templates section of the tool. So as Terry mentioned, eReg's templated approach to protocol creation helps to accelerate startup times. So these templates essentially serve as the protocol binder or the outline of the necessary documentation. Really, the goal here is to standardize the protocols and standardize the, essentially online binders so that you can make sure you're doing the same thing across the whole department or across the whole system, whatever you prefer. You can choose to either create your own regulatory template or you can use an existing template in the system. So we can go and look into one of the existing templates to show you what that all looks like. So IRB approvals and correspondence is one example of a section that's shown at the top here. So the sections of the template and the names of the sections are customizable or configurable, including the order that they're shown in. So these can be built, exactly to how you prefer them, what makes most sense to your organization. And the next section down in this template, we have staff credentials. Staff credentials are actually housed at a system level. So credentials are applied to all protocols linked to that staff member. So it really just takes one time updating the credential documentation for which it trickles down all the way through the system and no need to update it again and again. And then if we just look a little bit further down, you can see some of the other sections that are able to be included, including regulatory items for IRB and laboratory documentation, informed consent documents, protocol and amendments, all different types of sections here. And just as a note, even when you are using a template, you can always modify the outline at the protocol level for protocol specific changes. So you can use a template as your basis and just make small tweaks within the protocol itself. I guess I was gonna pause for questions if anybody had any, but I believe we'll be going straight through the chat. So I'm gonna keep going through, but I'd be happy to jump back into anything after my demo if you all have specific questions. So let's go into a protocol next. So from the protocol screen, I have this marked as one of my favorited protocols. This makes it so you can easily access which protocols you're specifically working on or that you're needing to access all the time. And so we'll go into the protocol itself. So from here, you land on the overview screen of the protocol. Here you can see general information about the study, any multi-site connections, status of training, delegation of authority, as well as document and signature statuses at a glance. Really just provides you all the basic information you need to know when you hop into the protocol. A really great feature of eReg is the document inbox function. So this allows you to quickly get documents into eReg with document integrations through email, through Advara's IRB Kirby, and other eIRBs. This makes getting the documents into the system simple and organized. For example, if your sponsor emails you protocol documents, all you have to do is forward it directly into the protocol inbox, as you'll see here. That makes it so there's no need to download documents out of your email, save them on your computer, re-upload them into eReg. You can just forward them into here and then directly review and file or reject if need be any documents. We can go into staff training next. So you're easily able to track staff training. And with Encore, you're able to integrate your staff information from Encore into eReg. You'll see this chart here, which is the document information related to staff training. You can, through eReg, access the staff training tracker. View the output here. Let me just pull it onto the screen that I'm sharing. This provides a really clear, printable, downloadable document that shows you all of the staff members that are related to this protocol, their staff role, start date, and any stop dates, and then the dates that they completed all of the different training documents, which you can see across the top here. And then I know delegation of authority is always a huge topic for eReg. So we can look at the delegation of authority at the protocol level here. eReg allows you to manage a completely electronic delegation of authority process. So organizations can either facilitate the delegation of authority workflow fully at the protocol level, or you can utilize the master delegation of authority workflow, which allows regulatory leadership to standardize delegated tasks at the system level. With the delegation of authority section in the protocol, as you can see here, you can easily see how many staff members right here need to sign off on tasks. Here you can see staff members that need PI sign off on tasks. And then here, staff members that need PI sign off on stop dates. So if you scroll down here, it gives detailed information as to this section here, which staff members need to sign off on tasks. You know, a little more specifics about what needs to be done. And then you can flip back and forth to see all of the different sections. And then a really great feature of eReg is you can view the delegation of authority report. This shows you the list of all the names on the staff list, again, their staff roles. And then you can see this chart showing their delegated tasks. We can customize a key directly for you to use with all of the delegated task codes. So this allows for one easy log or report where you can quickly pull all the delegation details into one document. Okay. And then we can head back into the protocol itself. So I'd really like to talk to you about some of the remote workflow capabilities that eReg really is strong with. So I'm going to show you how to easily upload and route a document for electronic signature. So in our example, we can go into FDA documentation. All you do is you hit new document, and we are going to choose a 1572. You can either choose it using this, or you can use drag and drop to make it very easy. You can add the effective date, valid until date, any comments that you would like to include. And then you'll see a signature requirement field at the bottom of this pop-up window. So we have three options available to you. Electronic signature is for documents that will be routed and signed within eReg. So here you would be able to choose the signers, including the option to send to all active staff or a specific staff role, which is really helpful, or a specific staff member. And then wet signature is for documents that were previously signed on paper and are just being uploaded to eReg for management, or you can indicate that the document does not need a signature. So we'll go through the electronic signature process. So the signers here, as mentioned, you can route to all active protocol staff. You can choose an active staff role or pick a specific staff member. So this would go to the PI, and then we'll have the signature meaning listed as approved. You can choose a due date, add any note to signers, and then you'll see this little option down here for the notify now field. When routing credentials and documents, you have the option of notifying the signer right away by hitting yes, that this document's ready for them to sign. This might be useful, for example, during study startup. And what it does is it sends an email to the person who needs it to be signed right away versus going through their digest email notification. If you choose no, it will go through the digest notifications, and those are customizable for each user. So you can choose to get that email daily, you can have it weekly, or you can have it monthly. You can also choose specific dates, specific times to make it easiest for you to work with your schedule as to when you would normally be looking to do those signatures. Okay. And then we can take a quick look at what the email looks like when you're getting the notification. So this is just a quick snapshot of what the text looks like coming in when you're doing your email, or excuse me, when you're getting your email notification that you have a document within eReg that needs a signature. So here you can see the link that would need to be clicked. And this whole process, as an additional bonus, is mobile optimized. So all, say the PI needs to do is click this link in their phone. And then this is what it would look like, this example in the iPhone, to show what it looks like needing to add the username. You can see all of the signed documents that would be available for signature. And then when they actually go to sign the document, they would need to enter their username and their PIN, similar to how they would if they were at a computer, which we know everyone's not at their computer all the time. So we wanted to limit the number of barriers to getting things signed to make it easiest for you all to get things done. Okay. And then we can go into the Signed Documents tab just to show you what it looks like on the computer here. So very similar to the slide that I showed you the mobile optimization. So what needs to be done is the document needs to be looked at itself. You hit sign, and then same thing, you enter your username and your PIN, and that's how it gets signed in the Part 11 compliant signature process. And then one last really great feature of eReg is the ability to do remote monitoring. So we can easily and securely allow remote access to sponsors and monitors. So if we take a look into a review session, it follows the same general outline as the protocol binders with the outline on the left-hand side. The sections being specified as part of the review session are available to view by the reviewer only within the start date, stop date timeframe. So when creating a review session, the start date is mandatory to make sure that the system knows when to provide that access. The stop date has the option to add it either when the review session is created, or you can add that value later on if you're not sure exactly when that access needs to end. It's very easy to configure review sessions. All you do is go into Actions, Configure Review Sessions, and then here you can edit any review session details. You can choose which sections themselves should be included in the review session. And then underneath each section, you can choose to include or not include any different requirements depending on what needs to be looked at. So you can see all of the different options here. And then if you go back into the review session itself, you would be able to see it as the monitor would be looking at it as well. So it provides a really easy double check. Exactly what you see here is exactly what they'll be looking at. It's super simple. And then we can just use the eReg logo to get back to the home screen. That's just a really quick overview of eReg. I think we can hop into the chat to see what everyone wants to see more of and what questions we have.
Great, thanks, Angelina. So one of the questions that came in is there a way to customize the email to add the university or hospital logo?
There's not that I know of. I actually was just chatting with our eReg team to get a response from them, and they just chimed in. So the current Email notification is not customizable to add a logo, but that request has already been passed on to our product team just now. So certainly we'll get that on their radar as a suggestion.
Great, thanks. And certainly feel free to add any questions to the chat. There was one earlier that Mackenzie was able to answer in the chat, but might be good for the larger group here. And the question was, the binder just stores the documents, but there's no way to edit within the binder, correct?
Yep, exactly. So the system is really meant for managing your documents, routing them for signature, electronically signing them. More of that document authoring or editing would be done outside of the system. So we do certainly have organizations that store maybe in progress versions of documents in the binder that they simply want or need to have within eReg. And then once they have finalized versions, those are the ones that they route for signature. But the actual process of that editing would be done outside of eReg.
Great, thanks. So it doesn't look like we have any other questions at this time, but certainly feel free to, oh, there's one that just came in. How long will eReg be supported by the university? So I think that might be more of a question for Allison or Deb. I'm not sure if Deb's joined.
I can answer it.
Hi, Allison.
Hey. So I would say it depends on how much uptake we have, what the demand is. But right now, the plan is to continue to support it using a fee-for-service model. So for industry-funded research, there will be a $1,000 one-time fee. So as long as we can sustain it that way, then it'll keep going.
Great. Thanks, Allison.
It does look like there is a question in the chat that Angelina has popped into to start off here, asking just to see this FDA documentation section. And I will say this is very much an example of what could be housed within the section, what requirements you would include, which of those are actually mandatory. So we have it as, under this FDA documentation section, we're keeping 1571, 72 sample labels, but that's all configurable. So that will come from a regulatory template, and determining which of the requirements are mandatory is also configurable. So very much just an example that you're looking at. Certainly can set it up in whatever way makes the most sense to you.
Great, thanks. And then Allison, it looks like there might be a couple more questions for you that popped up.
Yeah.
The question was, when, any idea when studies done at Children's will be able to use eReg?
So the MOU went back to Children's 2 weeks ago, I think. So it's with their legal department. So as soon as we get that signed, we'll be able to include children's studies.
Great, thanks. And then there was a question on cost for IITs.
There is no cost as long as I have the system. So while I know everybody wants to put their non-industry in, if you want to keep the system, I need you to put your industry studies in so that we can the model will work.
Okay, great. It looks like we have two more here for CU staff. To what extent is InfoEd integrated? For example, will CITI trainings from InfoEd pull over into eReg?
And I could take that one from more of an eReg capability standpoint, if that's helpful. So the integrations that we offer today are really focused more around the Encore integration, so sharing protocol level information, staff roles, And then 2, around getting protocol level documents into the system. So we do have integration with local IRB systems where you can automatically on a preferred basis bring in documents that are approved by the IRB. However, we don't have more of that staff credential level integration available today.
Great, thanks so much. So I think that concludes our portion of the training today. So I want to be respectful of everyone's time and hand it over to Michelle. But Paul, if you reach out to Ben, I think, and he might say at the end, how you can access the recording of this training.
Yeah, Matt will post it on our Clinical Research Connections website. And so, yeah, we can, if you have questions about that, you can email the Clinical Research Connections email address and we'll get you to it.
And also the recording and slides from this presentation will be emailed out to anybody who registered for the meeting. So it takes a day or two for it to process and upload. So expect probably by the end of the week, anybody who registered for this meeting will be included in the email that the recording will be sent out to.
Great. Well, thank you so much, everyone, for your time.
Thank you.
Thanks.
All right.
And now, yep, sorry. Go ahead,
No, you're
Rachel.
good. All right, so we're going to transition. Give me 1 minute to get my slides up and running. Okay. So are you seeing my shared screen? Are you seeing? I'm not seeing the green box. Are you seeing my screen?
We can see your screen the way you just had it before. We see just Outlook now. That's presenter view. Perfect, you got it.
Okay, excellent. I don't know why that green box isn't coming up for me. Hi, everyone. Good afternoon. My name is Michelle Edelman. I'm the Data Services Program Director here at Health Data Compass. Today, I'm going to just give a brief introduction to who we are at Health Data Compass, what data we have available, and how best to work with us and what services we provide. All right, so first of all, we are stewards of the data. We don't own any of the data that's in our data warehouse, and this is really important, especially when it comes to some of the compliance steps required to release the data. Additionally, we're informaticists with expertise in healthcare data, and we're working very closely with the clinicians, statisticians, and privacy officers and security officers on campus, which are the true experts in those fields. Health Data Compass has an enterprise data warehouse that is contained of our 4 partner institutions. Our 4 partners include UC Health, Children's Hospital Colorado, CU Medicine, and CU Anschutz. If you're employed by one of these 4 institutions, then you're part of our core customer base, and we're here to really try to service your data needs for research and quality improvement purposes. The data we have in our data warehouse includes the discrete medical record information from UC Health and Children's Hospital Colorado. So this includes labs, procedures, medications, flow sheet information, encounter details, provider details, all of that rich data from the medical record. And we have data from the UC Health and Children's Hospital Colorado systems. What that means, so for UC Health, we've got the 12 different hospitals within their system. And there's about 4 million patients within the UC Health system. There's about 2 million patients within the Children's Hospital Colorado system that we can access. In addition to this medical record data, we also have data from CU Medicine. So when a patient goes to the Anschutz Hospital, oftentimes they'll get 2 bills, one from the hospital billing and the other one from the provider billing. Bottom line, we have the billing codes for each of those bills that patient receives. Additionally, we have data from CU Anschutz. So the trivia information for the day is that there are CU Anschutz patients, patients that go to the Barbara Davis Center or the Hemophilia Thrombosis Center are legally considered CU Anschutz patients, even though their information is recorded within the Children's Hospital Colorado system, EMR system. Bottom line, we got that data too. We also have data from the genomic, from the CCPM biobank, which is collecting genomic data on their patients and their participants. Objective of Compass is really to understand what's happening to the patient as a whole, not just what's happening to the patient within a specific hospital system. And excuse my voice, I'm recovering from an illness. So to that extent, we also have date of death and cause of death from the Colorado Department of Public Health and Environment. And we have the civic data. Civic hosts the all-payer claims data, which means that you can see healthcare utilization that's happening even outside of the hospital systems that are part of our four partners. So if a patient has a clinical relationship with UC Health or Children's Hospital Colorado, we can also see the claims data that is that happened at National Jewish or in their hometown, assuming that the insurance company is mandated to report to the central database hosted by Civic. We see that this covers about 70% of the patients that have a clinical relationship with UC Health or Children's. And that's the Civic data. So the other piece of information that we have is on geocoding information. So we've partnered with a company called Melissa Data. We've been able to get the elevation, latitude, longitude, and census block information from the patient address, both current and historical. And we've been able, at that point, we can now link that census block data for the patient address to the census data hosted by the US Census Bureau to get at social determinants of health type of variables for these patients. Of course, there's limitations to the data that we have available. Our limitations include the fact that it takes time to get data into our data warehouse. This means that for our partner institutions, UC Health, CU Medicine, and Children's, we typically have access to last week's data, which is really great for research and quality improvement purposes, but we don't know what's happening in the ED right now. And we are subject to Epic upgrades and other things that are happening along the pipeline that may interrupt that data. Our external data sources have different cadences than 1 week. So the CDPHE data comes once a month, Civic data is twice a year. Additionally, although we know what was billed within both of those hospitals, we don't have the dollar figures associated with those billing costs. That's proprietary and stays with the hospitals. You may have heard me say we have access to the discrete elements, and there's a lot of the data in the EMR are discrete elements, but there are things that are not discrete elements. So those include things that are scanned into the EMR. So anything in that media tab, anything that's a PDF, we can't read that information at this point. Secondly, free text notes are not considered not discrete fields. So anytime that the provider is writing in a paragraph format, whether that's progress notes, discharge summaries, radiology reports, pathology reports, all of that information comes to us as a blob. We can deliver that paragraph back to you, although there's some storage considerations to take there because that's a lot of data. But bottom line, it's going to require one of you or your study team to go in and read the note, whether that's in the note we send you or through hyperspace to extract the information. We continue working on natural language processing to try to get term extraction out of those notes. The other thing that's important to know is that there's things that are restricted by the hospitals. These things typically include behavioral health, mental health encounters, substance abuse, childhood neglect type of encounters. All of that information that's flagged by the hospitals as being restricted will pop up as, you'll have that, if you're in hyperspace, you'll have that pop-up window saying, hey, are you sure you want to break the glass? That information does come to Compass, but it is typically filtered out of a standard report unless you specifically ask for it. So if you have a mental health focused research project, you can still work with Compass, but you need to ask for that information specifically. Finally, if you're only looking for children's data, those are serviced by the Children's Research Informatics team. As we pull and access that children's data, we're working side by side with an analyst from this Children's Research Informatics team. And so if you're only looking for that children's data, there's really no role for Compass. But if you're looking for UC Health or one of those external data sources, then that's best serviced by Compass, and will be partnering with the Children's Research Informatics team. Okay, so what Health Data Compass has done is we've been able to get all of the paperwork, the agreements in place to access all of this data. We upload it into our data warehouse, which is hosted within the Google Cloud Platform. We link the records together so that we know which UC Health patient is which patient at Children's Hospital Colorado, or any of the external data sources. We've transformed the data model into an OMOP, which is a common data model. And this can be really helpful, especially for multi-institutional studies where you're trying to pull the same information from UC Health as Children's or another external university. We've also continued to work on harmonizing the terminology. So from the EMR system, oftentimes those labs, procedures, medications do not come with a standard code. They don't have a LOINC code, a RX norm code, a CPT code associated with that concept. And we've worked to map that. That is still an active process, but for example, for labs, 50% of the labs coming from the source have a LOINC code associated with it, which means if you're only trying to pull that with LOINC codes, you're going to miss 50% of the data potentially. And so we've now mapped that, and 99% of the labs are now mapped to LOINC codes. So we can speak the same language. You can tell us, hey, when I mean platelets or hemoglobin A1C, this is the LOINC code that I'm talking about. And so that helps us with making sure that we're pulling exactly what you need. And then we populate data marts back out. We populate data and get that back out to you in a variety of different ways. We have a self-service cohort tool called TriNetX. And then the majority of what we do is we deliver line level data, assuming that you need PHI, that's going to go to a secure server, which includes RedCap, one of the local secure servers, or Eureka, which is an environment that Compass hosts in the cloud that's HIPAA compliant and secure. To give you a sense of what you can do with the data that's in our data warehouse, here's 4 use cases of things we've supported. So one, you really do have the ability to collect more comprehensive data than ever before. One study team was looking at whether air quality influences asthma exacerbation. We're able to identify patients who have asthma through diagnosis codes. We could have also used labs or medications. We then pulled from the EMR information about confounding variables as well as outcomes. And then we were able to give them the latitude and longitude for that patient address. They were then able to link the latitude and longitude to publicly available air quality data to get the data set that they needed to answer this question. You also have the ability to look at trends over time. This is much of what the data requests, the use cases for the data requests. So we have data from when Epic went live at each of the hospitals. UC Health Anschutz campus went live in 2011. The other clinics are more recent than that. The children's data goes back earlier than that. And depending on what data you're looking at, the children's data really becomes robust around 2008. And with that, now nearly 10 years worth of data, you can look at what factors contribute to a specific clinical event like readmissions after spine surgeries. Leveraging that civic data, there's study teams that are looking to improve patient care. So one example is a group that was looking at non-epileptic seizure patients. Non-epileptic seizure patients often present as if they have epilepsy, and so are misdiagnosed and mistreated for some time, even before that patient comes to the UC Health system. By leveraging that data from Civic, which gives you the claims data from other places within the state of Colorado where that patient's been serviced for healthcare, their healthcare needs, they've been able to identify and look for patterns of where the patients were treated before they came to their clinic. Finally, with that CDPHE data, anytime that you're looking to contact patients, that CDPHE data can be really critical to determine which patients are truly eligible and exclude the patients that are deceased. And so that's one way in which that CDPHE data can really be leveraged. In addition to that, all of those phenotypic use cases, you can also pair the data from the EMR and the external data sources to the genomic data. If you've got enough representation of your cohort within the CCPM biobank. So the CCPM have now recruited over 200,000 participants and have collected 99,000 samples. Right now, there's 34,000 of these samples that have already been genotyped with 1.8 million variants of DNA. And so what this means is that you can now really start to drive towards questions about personalized medicine. How does someone's DNA impact the treatment outcomes of that patient? And if you're interested in knowing more about these variants that are available, please go to the Translational Informatics Services website, which is down here in the bottom right corner. Right. So that's who we are and what data we have available. Typically, I pause and ask for questions here. I don't know if I can see the chat in this screenshot. Actually, yeah.
Michelle, if I can read out anything in chat if they come up, feel free to put questions in chat. Currently, there's nothing there, but as questions come in, I'll let you know.
All right, thank you. I appreciate that, Matt. All right, so next we're going to transition to details on what services we provide. So first of all, let's talk about TriNetX. TriNetX is that self-service cohort tool. This is an application that as soon as you sign our data agreement, you can get access to. And this really at your fingertips allows for some cohort feasibility questions. And so when you're at a point where you've got a great idea, but you don't even know if you've got enough, if there's going to be enough patients in your ideal cohort to do your study, TriNetX is a really great tool for that. And so when you log into TriNetX at your fingertips, you can put your inclusion criteria into the must-haves and your exclusion criteria into your cannot-haves. Using these events, you can select and filter on some time parameters. You can also filter by some demographic information. Hit the count patients button, and at your fingertips, you get a high-level count of the number of patients that meet this criteria. And so this is a really great way to figure out if you've got enough power to do your study or what compromises you might need to make to your ideal population to get to be appropriately powered. You can also click on this Explore Cohort tab and get some high-level demographic information on the patient cohort that you just identified. If you're interested in connecting to TriNetX, go to our website, healthdatacompass.org. On the second tab here is Data Delivery Services. And this first section up here talks about TriNetX. The first thing you need to do is click on this De-Identified Data Access Agreement. This will send you to a 2-page DocuSign agreement saying you'll treat the data responsibly. Make sure that you click that you want to use TriNetX. And within 2 business days, we'll get you access to that application. So TriNetX is helpful for that feasibility stage, but it's not going to get you that line level data that you need for your statistical analyses. When you're at a state where you know generally what specific patients and what variables you need, so I see your question, Christy, about being able to filter by the region and location. And the region is something that you can you can't filter, but you can see the high level counts in a different tab. We are also working on a new tool, and in that tool we'll have a lot more control over what's available. Right now, a lot of that goes through TriNetX as a company, and we support the underlying data for that. And so we've had less control over that customization. We are working on a new self-service tool that will be able to give you more detailed location information. So at this point, no, you can't figure out of those patients how many are at the UCH Highlands Ranch. You could figure out whether it was metro, north or south regions, but that's less helpful. And we understand that we are working towards a different solution, but that solution looks like it'll be in a different application. All right, so when you're looking for a line level analytical data set, that's really when you need to connect with Compass and request a custom data request process. To do that, the first thing that you need to do is go to our website, healthdatacompass.org, and on the front page, you need to click on the request a custom data set button. This will take you to a REDCap questionnaire, which will give you some high-level information or ask you for some high-level information about your project. So once you do that, then you'll get an email back from us giving you some guidelines of what the timeline looks like before your consultation, and asking you to do some general information, including the Compass orientation, and fill out a data request checklist. These are prereqs and things that will really help expedite the work with Compass once you have a dedicated analyst. Once your time in line has come up, then we'll connect you to a lead analyst and conduct a personal consultation. In that consultation is when we're going to dig deep into what you need for your project. How do we go from the 12 different hospitals, 4 million patients worth of EMR data within the UC Health system, down to specifically what you need for your project. And that data request checklist will hopefully prepare you for the types of nitpicky questions that we have to ask to get to that information. After that personal consultation meeting, there'll be continued refinement, making sure that we've got exactly what you're looking for, and we'll look for your sign off saying, yes, these are the project requirements. This is what I need. At that point, we're going to take that and review that as a team, try and make sure there's no holes in what you're asking for, anything else that the entire team can see. We write hundreds of lines of SQL code to pull that data out of the data warehouse, and we conduct quality checks. So we go line by line through that code, making sure that there's no bugs. We hire students to take a handful of that draft report and compare it to Hyperspace. Hyperspace is our source of truth. It is a flawed source of truth, but our objective is to accurately pull the information that's in Hyperspace. And then we conduct logical reviews where we're comparing the relationships between tables and variables, making sure that things make sense. That is the second piece of this, is once you have that personal consultation, we'll know specifically what you're looking for and with what level of sensitivity the data set you're requesting. At that point, we will send you the appropriate data agreement for your project. You'll read and sign that, and then we go and get approval by the Security and Compliance Committee. So this is where it's really important that we are stewards of the data. We don't own any of the data. We have to get permission from the data owners to release the data to you. The data owners are where that data originated, including UC Health, Children's, CU Medicine, CU Anschutz, and for that genomic data, the CCPM. The Security and Compliance Committee is made up of the security officers, privacy officers, and lawyers for each of our 4 partner institutions. So these are the true experts in compliance and security, and they're really there to make sure that Compass is not going to get the institution in trouble or have us getting us in trouble by releasing data that we shouldn't. And really, it's for those projects that have a COMERB approval, is to double check, making sure that there's no protocol mutation between what you ask COMERB for and what you're asking Compass for. The COMERB director is also on the Security and Compliance Committee and helps us when needed. Okay, what this means for you as far as the compliance piece is if you're looking for a de-identified data set, you need to sign our online data agreement form and you're good for a year. If you need PHI for research, you need IRB approval, just like if you got that data from anywhere else. There'll be a project-specific data agreement, as well as a request form, which gives some high-level information about your project. Please note that if you're looking for data from Compass and you are not looking to contact patients, then in general, you can use that secondary use research application by Cohort, which is a lot simpler than the full application. If you need data for quality improvement treatment payment operation purposes, you don't actually need IRB approval for us to release the data to you. There'll still be the data agreement as well as the project request form, which will go to the Security and Compliance Committee. They'll review it and help ensure that it's appropriately categorized. Okay, so once we get approval by the Security and Compliance Committee to release the data and the data has been built, it looks good, we're going to deliver that data. Assuming that you have PHI in that data, we are required to make sure that that PHI data set goes to a HIPAA compliant secure location. So we'll be gathering that information as part of that package to the SCC. And then as we deliver that data, we're going to be looking to connect with you and your study team, making sure that we're delivering the data that you need. And if there's any questions or concerns about the data we delivered, that we can answer it at that time. Okay, what we just described is our custom data pipeline. It is underwritten by the 4 partner institutions, so it's currently free for the data requester or the user. This means that we have a lot of demand for our services, and we prioritize those projects by readiness. We at the moment, you do need IRB approval before we connect you to a dedicated resource. We encourage you to submit that intake questionnaire as soon as you know you have an ask, and even before you have IRB approval. But by the time that you have, by the time we are dedicating a resource to you, we are looking for that IRB approval. Timeliness, if you have a hard deadline for a grant presentation, things like that, we are sensitive to that. We will do our best to meet those needs, but this is not a push of a button. Please come talk to us as soon as you know of that need so that we can try to meet that timeline. And then simplicity, things that are hypothesis-driven, focused projects will be prioritized more than, hey, give me everything within the EMR system. Finally, we continue to expedite work related to COVID-19. To give you a sense of what this means for us, we have delivered over 1,400 data sets since we really started this work in July of 2017. And 100 of those have been where we re-identify your TriNetX query and give you MRNs. But this means that we have 100 data requests in the queue at any one time. On average, we're delivering 1 data request per business day, but we're also receiving a little bit more than 1 request per business day. So that's ends up being pretty stable. What this means for you and for your project is that it does take time to get data from Compass. And of course, when we continue to work on ways to expedite the turnaround, but what you can expect right now is that if you can identify your cohort in TriNetX, and you simply need to re-identify that in MRNs, to do manual chart abstraction, then we can deliver that within 7 days, assuming that you've got your compliance documents in hand. All of the other projects are prioritized by the complexity and the amount of time that we think it's going to take. And in general, the extra smalls are modifications, expansions of other projects. So you're really looking at about 8 to 14 weeks from when you submit that survey to that personal consultation, which is why we're encouraging you to submit that intake questionnaire the moment that you know you've got to ask for Compass and before that Cohort approval. Assuming that you've filled out and thoroughly completed that project review, that project checklist, which means you've got all of the prerequisites. You can answer all of the questions that we have for you during that consultation meeting. The target is to deliver the data within 2 to 4 weeks after that consultation meeting. Please know that there are ways to expedite your project, but it costs money. I know we're at 1 o'clock, and so I'm gonna skip this. All right, so And if there's questions, I'm happy to stay online. Your take-home messages here are, we're informaticists and stewards of the data. We have data from our 4 partner institutions, UC Health, Children's, CU Medicine, CU Anschutz. We also have death data from CDPHE, that claims data from Civic, and geospatial data that can also be linked to census data from external sources. And we've got a self-service cohort discovery tool, custom data extractions, and we also have solutions for computing. If you've got challenges with storing data, especially big data, we also have a Eureka environment that we can connect you with. What questions, concerns can I answer?
I think, Michelle, in the respect for time, if people have meetings, we can take questions, but I just wanted to do a quick housekeeping before we leave. We'll save the poll for next time. I just wanted to let people know we want to ensure that the topics covered in this meeting are good for our audience. So I'm going to make sure everybody has the email for the Clinical Research Connections. Please send ideas, topic requests, any questions that you want here, and we can also reach out to speakers. A recording of this meeting is going to be sent out hopefully by the end of the week with slides. And I just wanted to do a plug that these will continue during summer. If you have registered for all meetings, it might not show up on your Outlook calendar. So make sure you cordon off 12 to 1 on the 3rd Tuesday of every month. And if you have questions, Michelle has gratefully said that she'd stay on. So please put them in chat. We'll hang out for as long as you want. Michelle, if you want to put your email in chat so people can reach out afterwards, possibly, please reach out to the Clinical Research Connections, Michelle directly, and we can connect you to the the E-Reg team, the Edinburgh E-Reg team, if you have any after questions for them as well. So we appreciate you joining. We'll see you next month, and please hang around if you have any questions for Michelle.